Thank you very much, Ram, for the kind introduction. I'll be talking about the monofocal plus lens, as it is now called, over the conventional monofocal lenses. The current monofocal lenses, as you all know, it has its limitation. The obvious advantage is that 100% of the light is used in a monofocal lens to come to a particular focus. But when you look at the quality of vision as it, or the quantity even of the vision, as you go on to the intermediate or the near, it tends to fall dramatically. Some patients who may be having some with the rule astigmatism in the cornea, etc., may have some intermediate vision, but by far distance vision quality is excellent, and the intermediate and near tends to fall down. Now, what are the known demerits of the bifocal? First of all, you got the bifocal lenses, you got the diffractive, you got the refractive version, etc. So, if you compare with the bi or the multi or the trifocal lenses which are there, the first and the foremost thing that happens is that you are splitting light. As and when you split light, you are not using 100% of the light for the same point focus, and therefore there are going to be problems, especially in dim light and when the contrast is poor at that particular point, which is for us, it is absolutely critical even for operating surgeons. When you go on to the other part, which at times can be rather harassing for you because the patient can be after your life, there can be a lot of brain damage that the patient does if the patient is not able to get out of the dysphotopsias, that is the glare and the halos that he has. IOL exchange is often heard of when we have done, patient is not adapting to it, and specifically the adaptations are very less forgiving if there is a residual refractive power or there is a toricity, there is a problem. Now, as even in my practice, I have not had to explant a single monofocal plus IOL ever since I have introduced, because the problem of dysphotopsias, glare, etc., I don't know anybody in the audience if they had needed to explant this monofocal plus IOL. Now, so this is just a comparison of what I have said, that EDOF, monofocal and trifocal, the main problems that come here is the dysphotopsias that you have, the patient satisfaction is much lower, but when you have a monofocal plus, you have no dysphotopsias, unaided intermediate vision is good, and the patient satisfaction is good. So, as we have transformed our life, unfortunately, we have become potato couches. We are not doing a lot of outdoor activities which used to be there, and going out with friends, etc. You are now slaves of the computer, the near work, you Google Maps, etc., etc. So this is what life is all about now today. So this is intermediate vision, and this is what we are looking at. So therefore, the need for having an active lifestyle is to have distance vision clarity, as also good intermediate vision. That is the important thing. Near vision, the concepts have changed. You don't do like very fine reading, etc. that is there. So the IOS lens, which is my go-to lens, we were just looking at our numbers. So we have used about 14,000 plus IOS lens in the last fiscal. So that's a big quantity of the lenses that we use, and that's our go-to lens today. So the first thing is no rings. If there are no rings, you will not have the problem of dysphotopsias, glare, etc. It is based on a continuous higher order aspheric surface. The surface in the central part is so modified that this is an aspheric surface, and it is visually indistinguishable. If you see it under the microscope, if you are implanting from a Technis 1, Technis 1 platform has been with you for ages, and it's been a fantastic lens with no glistening and great clarity for distance vision. So it also, as you know, is an aspheric lens like the Technis, and it tries to reduce the spherical aberration to near zero. Now this is how it looks. If you look at a Technis 1, you will see that it is the same, but this is this small little bump that is there, which is the zonal design. There is no abrupt change in power. So since there is no abrupt change in power, there is no dysphotopsia, no glare, etc. The periphery of the lens is absolutely identical to what the Technis 1 is, and the power is increasing continuously from the periphery to the center without any bumps, etc. So this is what the lens is all about. And if you see at the power map that is there, so you have spherical lenses which are there, which is this one. You have the Technis monofocal lens and you have the Technis eye hands. So they compensate for the asphericity. This does not compensate. This, both of them compensate the same way for the asphericity of the cornea. This is what it does. The central movement from the periphery to the center, it is, I would say, a mini EDOF lens, or whatever you wish to say. There is an intermediate range that comes about with this lens only because of the central change in the spherical aberration that is there, and this is what you have. So this is how you see, if you look at the on the model, you see that this is what is the eye hands and this is what is the single piece. So it provides improved intermediate vision without compromising on the distance vision. That is the main key thing. It does not compromise on the distance vision, and the distance vision is comparable to any good aspheric monofocal lens. It delivers photic phenomena profile which is similar to the aspheric monofocal and tries to, because of the negative asphericity like in the Technis, it tries to reduce the spherical aberration to near zero. Now when you compare it to the intermediate vision, that means what you are looking at the intermediate, if you look at both these, you can see that there is a 1.1 line difference which is there in these particular cases. So this provides statistically significant improvement at 66 centimeters. That means that is your intermediate. If you are a tall person, that's pretty good for you. Maybe shorter people, there may be a little problem from that, but you are looking at somewhere around 2040 that you are looking at. Now we did a study, there was a lot of issue about the stability, because I am going on to the second part of the talk, which is the toric lens stability. So Technis was supposed to be slightly unstable as regards its position, as regards toricity. So the company responded and they brought about what is known as the toric 2, which is basically the version wherein the little thing that has been done is that the haptics have been frosted. So that, what is the frosting of you had smooth glistening, they could slide a little bit, but if you frost something, there is friction. And this friction actually causes the capsule to stick, and that is why they stay where they are. So this is squared and frosted appearance, that is what you have with this particular lens, which is again a single piece lens which is there. So what we did was we compared 70 eyes, 35 Technis eye hands, and that is the toric 2 with 35 of the lens from another company. That is where they were said that this has the best stability which is there. Adult patients were used. So the irregular astigmatism, previous corneal surgery, etc., these are the same. So this was to compare the rotational stability, safety and visual outcome of the Technis IN's toric 2 with the Clarion toric. So when you are looking at the observations, the IHANS toric versus the Clarion toric, 2.1 degree was the rotation that we got versus the 2.9 degrees. So this is not statistically significant, but earlier the noise that was there is that you don't have stability in toric with the Technis lens. With the Technis 2, with the IHANS 2, this is no more relevant because it is as stable. In our study, it was found to be a little more stable. But when the real kick that came in was the uncorrected visual acuity at 3 months, when you're looking at the Snell's, there is no comparison. The distance visual acuity was comparable, but when you look at the intermediate and the near, you saw that the IHANS toric 2 performed much better than the Clarion toric which is there. The near ad requirement, according to in our patients, averaged about 1.5 diopters. As I told you, in my POC, it is 0.75 or something. So here it is between 1.25 to 1.75. In bilateral cases, it's slightly lower than 1.5 as compared to the other one, which is closer to about 2 diopters. So friends, at the end of the study or even otherwise, I don't ask the patient anything. The good thing that the company did was that this lens is not super highly priced. as compared to a monofocal lens. It's only marginally higher. So I don't even discuss with the patient. My go-to lens, or in our centers, the go-to lens is a monofocal plus from the Eyehance variety, because we have had excellent distance visual outcomes. It has been a glistening free lens. There is nothing wrong with the material. The material is great, low PCO rate, and specifically when you're coming to the toric version of it, it has outstanding rotational stability, and lifestyle wise, patients are virtually spectacle independent. So friends, this is what I have to say about this lens, which is my standard of care today for practice. Thank you very much for your kind attention. Thank